afternoon, everyone. I had a half bran muffin for lunch. Anybody have anything nicer than that? Yeah, so good morning. I meant it was a good morning, and good afternoon to you. So I'll be your moderator this afternoon for the Aboriginal Health and Child and Youth section of our program. And Melanie is that you, I guess. They asked me to do this. Well, but I'm not good at it. So Melanie's going to talk about building community partnerships to support vulnerable families, the Nurse Family Partnership. Yay.
Can you hear me now? Yeah. Whoa, it's really loud. Okay, so I'm just going to dive right in because time is of the essence. My project is called Building Community Partnerships to Support Vulnerable Families, the Nurse Family Partnership. And I did my practicum placement in VHA. It was a workplace placement within the perinatal redesign, so the right from the start and the BC Healthy Connections project. I work half-time as a BC Healthy Connections nurse, which is a nurse family partnership nurse in British Columbia, and my other half-time I do regular public health, which you guys now all know the scope and breadth of that. And my project was to raise awareness of the perinatal redesign within the Mount Waddington region to promote referrals of prenatal women to public health. So Mount Waddington is on the very north end of Vancouver Island. Can't go any farther, really. So looking at the mission of the redesign, it's using a population health and equity lens. So what you really want to do is promote the health of all prenatal women in BC, while seeking to raise the health status of those most in need. So when you look at that, up on the, I hope you guys can see it, there's universal services there on the left. So we're continuing to provide services to all pregnant women, but with more enhanced services to the more vulnerable subgroups. I'm trying to slow down, but I talk fast when I'm nervous. So I was excited to see in the guiding framework of public health document that came out from the Ministry of Health just recently. I got this quote from there, and really what it talks about is what happens in utero in the early years can have lifelong effects on many aspects of health and well-being. So looking at obesity, heart disease, mental health, and probably a lot of topics that we've been learning about over the last few semesters. So the Nurse Family Partnership is really focused on the enhanced services that is being offered. And so it's just a small piece of the whole umbrella of prenatal health services that are being offered in BC. And what the Nurse Family Partnership is it helps at-risk first-time moms have healthy pregnancies, improve child health and development, and become more economically self-sufficient. So moms are followed throughout pregnancy up until the child turns 2 years old. The eligibility criteria is under 25 years of age, first pregnancy, low income, and early in pregnancy. And really, it's focused around client-centered care. So although there's really significant, there's guidelines that guide the nurses who are working with these moms, it's about reaching, the moms reaching their heart's desire. So although there is some structure, it really is for supporting what moms would like to see in their lives. So just to give a little bit of background, the first randomized control trials happened in Elmira, New York in 1977, and in Memphis, Tennessee in 1988. If you look at some of the results, they were quite significant. In Elmira, we saw reduced rates of child abuse and neglect, reduced rates in ER visits for children, increased in prenatal nutrition, decreased prenatal kidney infections, and the preterm deliveries for smokers, there was a 75% reduction. There was also increased spacing between births for most of the most vulnerable moms. In Memphis, Tennessee, they also saw a decrease in rates of pregnancy-induced hypertension, hospital clinic visits, subsequent pregnancies, and something really notable was around children mortality. So the control group had a mortality rate 4.5 times higher than the NFP visited children. And when you look at this Memphis sample, it's important to note that 85% of the sample was at the poverty level or below. So it was some really vulnerable groups. So I'm just briefly going to go on my lit review because I really want to have time to be able to talk about my project. My lit review is in two parts. The first part was to look at recent literature published between 2000 and 2013 on the longitudinal studies that followed those initial trials that happened in Elmira and Memphis. And the second part was kind of for myself. I'm a nurse family partnership nurse, but I can't talk about that because it's part of a study, so I can't share my personal experience, although I would love to. So, you know, in the process of implementing a new program, there's always challenges. And so I really wanted to look at the challenges on an international level in places that have been implementing the program, just to see what they had identified, just to get a more global picture of what some challenges are. So I gathered the literature. For the first part, I just really focused on randomized controlled trials, so it was really specific, versus in the second part, I was looking a little bit more broad to see what evaluation things had been published. So I was just looking at what was available online. So when I looked at the key findings of Elmira, these were happening 15 years to 19 years after the randomized control trial. So just to remind you, the nurse-family partnership runs until the child's age 2. And so we're able to look at the teenagers that took part in the trials. Well, they were babies then, and then now they're teenagers. And so what they found is, looking at the moms, they found a decrease in binge drinking of moms, decreases rates of arrests and convictions for the girls that are now teenagers, decrease in emotional distress of moms, higher rates of condom use for youth born to high-risk moms, and it was interesting around child maltreatment rates. Something, if they wouldn't have been following these families long-term, they might have missed this. What they found is the rates were kind of the same for a certain period, and then after age 4, the rates of the nurse-family partnership visited children decreased, and they continued to decrease throughout school until they were non-existent, versus the control group continued to rise. So something was going on there, although they're not exactly sure what was causing with that long term. One interesting thing is there wasn't actually significant finding for boys. So boys in the study were not seen to have some of the positive results as the girls, so there's definitely further research needed there. When you look at Memphis, I was looking from 3 years to 12 years from the initial randomized control trial. And there was decreases in subsequent pregnancies, decreases of financial aid use, decrease in marijuana, alcohol smoking of the children, or teens, decrease in maternal role impairment due to drug or alcohol use, and decreased mental health disorders of children. So looking at the implications, it was pretty interesting to see with the long-term follow-up that benefits were lasting over a decade from the program. But further research is still needed whether NFP is going to be reproducible in other populations. So if you think about the Canadian context, we have a much different healthcare system than the States, as you know. And also, if you look at our geography, with our rural areas specifically, you know, there can be some more spacing between where people live. How is that going to work? How can we deliver the program? Also, if you look at our multicultural population and Aboriginal population as well. So, and also further research is really needed to explore the influence of gender on outcomes. So what I said before about that study not showing the results in boys. Hold on here. Okay, it's kind of skipped ahead here, that's great. So I looked at the implementation challenges and I divided them up into 4 factors. So nurse factors, client factors, community factors, and government factors. Now I would love to go over all of these, but I don't think I have the time. So I'm really going to focus on the one that really guided my project, which is under community factors, and it's that of community engagement. So my practicum project, to give a little bit of background in Mount Waddington, in October 2012, the right from the start perinatal registration was implemented. So what that was is the forms were delivered to providers in the community. There was a little bit of education around it, and they also got some emails encouraged them to register all prenatal women. Well, prenatal women were supposed to register themselves, but providers were supposed to encourage that. So between October 2012 and February 2013, there was really minimal registrations received. And in talking to members of the community, there seemed to be a lack of awareness around the perinatal redesign. So we're sort of in the situation where we have this program that we know has shown results in randomized controlled trials, and yet we don't have anyone in the program. And when you look at the Mount Waddington area, we have some really specific vulnerabilities there. If you look at the teen pregnancy rate, our teen pregnancy rate is 174% higher than the rest of Vancouver Island. Also, our rates of child abuse are 4 times more than the provincial average, and children in care are more than double than the provincial average. So it's clear that some more support is needed, and the Nurse Family Partnership has shown to have some positive outcomes on that. So it's really important to be able to get people connected to the program. So when I looked into the literature around the community factors that are needed for success, there was 4 real strong messages, and it was really around community awareness of the program, knowledge about the program, community support for the program, and quality collaboration between providers. And that seemed to be something that was really lacking in the process of putting out the program. So what I did is I put together, I modified some PowerPoints that had already previously been developed, and made them more applicable to the local context of Mount Waddington. And I actually did 2 presentations during my practicum, but I was invited to do some more presentations. And so I did 4 in total. They were mixed between multidisciplinary presentations and presentations focused on certain teams. And I'd love to talk about the strengths and challenges, but I'm not sure if I'll have enough time, so feel free to ask me about them in the question and answer. So some of the informal feedback I had from the information sessions is the lack of awareness of the redesign, uncertainty around the eligibility criteria, confusion on the referral process, the need for increased promotion of program, and registration barriers. A strong message I had was I wasn't only talking about the Nurse Family Partnership, I was really talking about the whole universal services and targeted services, and there seemed to be confusion that people thought they couldn't refer people unless they were a vulnerable population, when really we were trying to get all moms connected. So in conclusion, there's real need for ongoing partnership building, research of Nurse Family Partnership in the Canadian context, capacity building, and education that's focused on the health equity and the population approach. And I found this quote by UNICEF that really talks about how the true measure of a nation's standing is how well it attends to its children, their health and safety, their material security, their education and socialization, and the sense of being loved, valued, and included in the families and societies into which they were born. And we talk about traveling further upstream, and I think this program is really focusing on trying to connect with women as early as we can to really try and support them. So before I say questions, I'm just gonna click to my acknowledgement slide because I feel like I might miss it. Before I go there, I definitely missed some people. I know I got to this slide, I was in a panic to submit this. I'm sure all of you guys were not panicked. And so I just did it as quick as I can. So I did put a cute baby on there, just hopefully that makes up for some people I forgot. So I wanted to thank Marie DePero, who's actually been here for the last 2 days. She was my practicum supervisor, and my public health nursing team in Port Hardy, which Pam is now in Nanaimo, but I really couldn't have got through without them, and Catherine Worthington as well, and I also wanted to thank Lorene and Betty and everyone else that I forgot. So I made it in time, and hopefully I didn't talk too fast. 13 minutes.
Oh, I don't even Questions?
Great presentation. In terms of focusing on low-income individuals, was there any collaboration with Ministry of Social Development to identify these individuals and connect with them if you're having a difficult time getting individuals involved with this program?
That's a great question. One of the things about the program is because it's client-driven, we really wanted the clients to be referring themselves. So what I was trying to do is really try and get representatives from as many programs that I could think of in the community that connect with moms. So I sent out invitations to like MCFD, to the Crisis Center, to physicians, nurse practitioners, pretty much everything we could think of. And also, I wanted to say too, I mean, we've heard a lot today about the on-reserve, off-reserve, and that's an issue as well, because sometimes there's been kind of like this artificial barrier where, you know, we're not providing services there, but we may have clients that are fluently moving between on and off reserve. So it was really exciting to be able to connect with them and invite them to come in, and they get to know who we are and we get to know who they are. And it was interesting to hear what they thought the barriers were and just to leave it open to everybody. So I hope that answers your question. We kind of just tried to have it at kind of a community level. Anybody else?
Who would have a heart attack? Just a quick question. What is the relationship? Because when you mentioned, like, we've had some discussion over the family partnership program over the course of the last 2 years. What is that role with Ministry of Children and Families?
Which tool to do this?
That's a good question. There isn't really a direct role that I can see. Like, it's basically a public health nurse partnership, so a partnership between the nurse and the client. The only time the ministry would get involved is, you know, there is those situations where you have to report to the ministry. If there was some issue with child protection or something like that, and that's when they would come in. That being said, we've been working really hard in our area to try and build more relationships with the ministry in the sense of how can we support clients better and maybe, you know, work together with the ministry so we're not getting into those situations where they don't necessarily know the whole picture, right? So I would say there isn't a direct relationship.
That's awesome for addressing it. Yeah, I just think you know, historically with that relationship and having someone come into a role that has that duty to report. So how do you make sure that the client is feeling safe? Because I know if you came into my home, if I had children, you would probably take them away from me because I have clothes on my floor. Like, you know, just working. But you know, it's social structures and stuff like that where I think this is an amazing opportunity. But how do you create that safety for them?
Well, luckily, public health nurses have been going into people's homes for a long time. And in Mount Washington, believe me, I'm actually more concerned if people don't have clothes on the floor. I'm actually giving them a lecture to say, you're doing too much, you have a new baby, how can we support you, self-care. So I think because public health nurses have been going into people's homes for many, many years, we're just sort of changing how we do things to sort of look at how can we support the most vulnerable better, rather than just doing a home visit just to do a home visit, because I think for some clients that was happening, and now we're trying to really bring those services to, and honestly for some people, if they're saying, I don't want you in your home, in my home, then we don't go in their home. We'll offer the service somewhere else, so it's very client-centered.
Awesome, thank you.
Oh, yeah. Got a mic. I can just see me going. My skirt.
Hi, Mel. I would just like to know, just for probably discussion for the whole group or sharing of knowledge, offering this service in a rural and remote area, what would you see the role of some of the community partners in helping support these vulnerable mothers?
They are bringing some batteries.
So once again, I think we get back to the foundation of it all, which is relationship building and community building. And I think we all know, like in the research, it's pretty clear that if people are all working together to support a mom, you know, it takes a family to raise a child, and I think it's the same with the vulnerable people. If we're having disjointed services where no one's talking to each other and we're not supporting each other, I think it causes some huge gaps where people fall through. So I think we have a lot of community services out there, and I think when we're talking about on reserve and off reserve, there's some services that are fabulous on reserve, and with our clients, it's really up to them where they want to have services. And for some people, they're really well connected on reserve, but they might want to come see us off reserve, or they might not. So it's just checking with them and letting them guide us which way they want to go, and you know, supporting their heart's desire and for healthy children and healthy moms.
I think we're going to have to move along. That's okay. Jen? Jen? That was not good. So next we're going to hear from Jen Brennan, whose presentation title is really long. So I'm going to say it. So you can say your presentation. It's really long. It's got to do with public health in schools. You don't remember? I'll read it out, Jackie.
I was in the Haiti.
I'll talk about these as I go. So I'm using this then?
Yeah.
Okay. Hello. So I'm going to talk today about my presentation, which was the short version of it is the Comprehensive School Health and Public Health Nursing in the School Setting. So I'm going to discuss the process that was undertaken to complete the Culminating project on this subject. So I'm going to take you, this is my attempt at being clever, into the details of the scoping review. So I completed my practicum at the Directorate of Agencies for School Health, which was mentioned very briefly this morning. It's also known as DASH BC. And DASH is a non-government organization based out of Vancouver that supports the health and education sectors in implementing CSH initiatives. And my project involves 3 components, and the first of which was a 20-page CSH resource guide that was specifically tailored to public health nurses and the public health nursing audience. The second component is this lovely one-pager, which I'm learning so much lingo as I go into the nonprofit sector here. So the one-pager is like pretty much a executive summary style, a little bit of a marketing grab for the audience. If they don't have time to read the resource guide, here's your one-pager, here's the information, and come and see me if you need to know more. And then finally, I made this flashcard deck of all these examples of tangible examples of what public health nurses could do on the ground if they want to know how to implement CSH, and also information about where else to go if they want to find out more. So collectively, these resources were meant to provide multiple options for disseminating CSH concepts and hopefully support PHNs in implementing this approach in their currently existing work that they do with schools. So what is comprehensive school health? Well, Pam really did a good introduction to it, so yay for me. So I'll just kind of read out, according to the Joint Consortium for School Health, it's an internationally recognized framework for supporting improvements in students' educational outcomes, while also addressing school health in a planned, integrated, and holistic way. And comprehensive school health is based on coordinating actions across 4 distinct pillars. And one thing that I like to talk about, I've already done a couple learning sessions with this. It's been a great experience, and what I've kind of talked about is that yes, you can implement a Healthy Schools action in any one of these pillars, and it will affect health and learning outcomes of the students. But the key messaging here is that when you coordinate actions across pillars, you're optimizing health and learning. So that's kind of what we're trying to get at here. So the next part I'm talking about briefly is why public health nurses? Why did I choose this group to focus on? Well, for one thing, they are a frequent first point of contact for schools that are seeking health promotion or injury or illness prevention, education and services. They are recognized both in the literature and in the consultations that I undertook, which I'll talk about a bit later, as important stakeholders in CSH initiatives. And they also practice according to a lot of the same foundational concepts as the CSH approach, including intersectoral collaboration, community empowerment, and capacity building. So moving on to the purpose of the report, which is what I completed on how I did the project. So the purpose was to provide the reader with an account of some of the currently available evidence around why public health nurses are integral to the successful implementation of CSH initiatives. So I'm highlighting the word why here because we'll get to the difference of do they or don't they, and why is that so. So the chosen methodology for the project was a scoping review, which involved an iterative approach to identifying the breadth of the literature that currently exists around this subject. And I had three main objectives here, and the first was to identify existing literature that related to the partnerships with the health, identify existing literature related to comprehensive school health on the partnerships that exist in the health sector, specifically focusing on public health nurses. The second was to identify existing literature that related to public health nursing, specifically in the school setting. And the third was to identify potential gaps in the literature and areas for future inquiry that could contribute to a better understanding of how these two concepts align. So I chose the scoping review instead of a more involved systematic review because the amount of literature that focuses on how public health nurses or how public health nursing aligns with CSH is actually currently quite limited. And I'm not talking about whether public health nursing is mentioned in the same documentation as CSH, because it definitely is. There's not really a lot of language out there talking about why is this so, what are the concepts, where are the alignments, why are they important. The goal I was going for was breadth over depth, and this came from the identification with the organization I was working with. They didn't really understand much about PHNs as a stakeholder. All they knew was, we keep hearing that PHNs are really important and we need to connect with them. Can you figure out why that is? And so I thought, okay, I'm going to go figure out what is out there that can help me. And I wanted to contribute to future practice in this area. In order to do that, I kind of had to start at the beginning, which was, what is out there? Because I didn't really know at this point. So following, somebody else mentioned this yesterday, I think, Arksy and O'Malley's 5 stages of scoping review, I started by identifying my research question, which was, how does the comprehensive school health approach align with public health nursing practice in the school setting? And the two words, how and align, again, I'm going to emphasize that they're the crux of this question because they mark the difference between identifying what most literature discusses, which is, yes, PHNs are a key stakeholder group, and exactly why is that so? Stage 2 involved identification of relevant literature from the following sources, and I used keywords such as comprehensive school health, health promoting schools, coordinated school health. These are all, you may or may not know, interchangeable terms that have been used to refer to CSH in different settings, so I wanted to try to catch as much literature as I possibly could. Stage 3 of the process was literature selection, and this was an iterative process, and it ended up taking the form of 2 phases because I quickly realized that what I had set out to do was slightly too narrow to actually find anything. So the first phase, I only wanted articles that were published in the English language in 2005 or later, was referencing PHN practice in the school setting and CSH in the same document, and they had to be published in Canada and or include Canadian-specific content. And I chose the year 2005 just because this is when the Joint Consortium for School Health actually developed the Comprehensive School Health Framework as we know it today. Of course, the concepts they date back over 20 years, but the actual framework was developed by the JCSH in 2005. So through all this work, I ended up with a fabulous 3 articles that was not good enough to talk about today. So I thought, well, I'm going to do something about this. So I made a few modifications, and I broadened it to include articles that pertain to either PHN practice in the school setting or CSH. And I did this because I thought, well, maybe if I can just find some areas where there could be alignments, I could create those alignments myself and talk about where they could potentially align. Just because the literature is not saying they're aligning doesn't mean they don't. It means that I just have a little more thinking to do. And I wanted some articles that would be relevant to the Canadian content, so maybe not specifically mentioning Canada, but the content as in using words like health promoting schools or coordinating schools' health as it's often known in the United States. How could that be relevant to Canada? So 28 articles, and I had myself a project. So then I decided to plot this literature out and look really smart about it. And so here's my literature selection flow chart. Articles were excluded in this process for one of 3 reasons. They either didn't meet the inclusion criteria, which I'm going by the second phase here when I talk about inclusion criteria. They didn't meet the key characteristics of CSH or public health nursing, or eventually I ended up excluding a whole 7 articles at the end because they just didn't really suit the purpose of what I wanted to talk about. Like, sometimes they would mention PHN as a stakeholder, or they talk about CSH, but they really didn't get into the meat and potatoes of, like, what is this and how do we use this? So I ended up with 12 resources that actually went into this resource guide in the end. And although it wasn't very many, what I had was very rich in content, it was very relevant, and it ended up producing something incredibly useful, which I can talk about at the end. So stage 4, I charted the data to increase the transparency and the replicability of my strategy. So I charted it according to the following key characteristics. And this was on all 28 articles that I had retrieved, not just the 12 that I ended up including. And finally, I was interpreting the results of this, and the results interpretation, I decided to take it into 2 stages. First was the informal consultation. So I conducted informal consultations with 9 field experts that came from the areas of public health nursing, the healthy schools nonprofit sector, and the education sector. And so it was really interesting to find out what they had to say. And the first thing was that they unanimously agreed that PHNs are an important stakeholder for CSH. There was no qualm about that. The PHNs that I interviewed, there was 5 of them, they unanimously agreed that not all PHNs are familiar with CSH concepts right now. And some of the familiarity, actually, it really varies across the province, from some that have actually received learning sessions on CSH and are starting to use it, to other ones that have no idea what it is. And finally, the PHNs all express a desire to learn more about CSH, which is really important because it gives us a basis for moving this forward and actually going in. If we have a captive audience and we know that we have buy-in from the PHN sector, this is perfect. We have some place to go with this. So the results of the literature review were that a whole 3 of 28 articles discussed comprehensive school health and public health nursing in the same document. I didn't retrieve any articles that discussed how public health nursing aligns with comprehensive school health. And I didn't find any actual studies, like research studies, that evaluated the effect of CSH on public health nursing practice or vice versa. So I'll talk a little bit more about that in my future implications and recommendations. So what to make of all this? It became apparent that there is literature out there that identifies PHNs as an important stakeholder, and there is even literature written from the nursing perspective that points to CSH as an active component of their healthy schools work. But beyond the identification of these 2 concepts as being very relevant to the other, the question remains, but why? So given that public health nursing and CSH view the health of the individual as part of a greater system of environmental factors that influence health, I started to pull concepts and language out of each of these articles, and I started to see, you know what, the socio-ecological model is a commonality here between the two of them. And for those people who are trying to remember what the socio-ecological model is, there you have it. So I've actually found language in both public health nursing and CSH articles that explicitly positions them within this. You can either call it a socio-ecological or a socio-environmental model of practice. But what was really interesting, like, this is not a revelation, this is nothing really new. It's just, it's interesting to note that this commonality was not mentioned in a single article that I've came across. So the strengths of the project that I completed were that the consultations, they have provided me with a lot of valuable data, and they helped to guide and direct this project in a way that I would not have been able to do so had I not actually connected with these experts. This process was quite transparent and replicable, which I think was very important coming from a perspective of not actually knowing anything about it. So I'm happy to say that if someone else wanted to come along and continue this work, I think they could probably find exactly where I had found everything. And as far as I know, please tell me if you see otherwise, this is the first scoping review to be done on this topic. I couldn't find any other work that's actually talking about scoping why PHNs are such an important stakeholder to CSH initiatives. I couldn't find any literature out there saying so. I'd be really happy to know if there is, though. And there was a lot of limitations, actually, probably more so than the strengths, but because I want to look good, I've only put 2 limitations in here. So gotta have the, you know, more strengths than limitations. So one of the biggest ones was that the literature search was not exhaustive and it was not a representative sample. There is a lot of literature out there that does discuss public health nurses and comprehensive school health. It did not come up in my literature search. And this could be very well due to the keywords that I used. It could be due to the databases that I searched, more so the databases that I didn't search. And the fact that my research question is incredibly narrowly focused. So that was a big limitation to this. The consultations, although they were very, very helpful, they were selected out of convenience, and they did introduce probably some bias into the actual findings of this. They were all from BC, so they're not really a representative sample of their respective organizations, but they were very valuable nonetheless. And as far as conclusions for what I've done, I've identified that there is a need for future research and practice around the effect of incorporating a CSH approach into public health nursing practice and vice versa. Where this actually has been done, it hasn't really been documented yet. I couldn't find any evaluative studies, and I would really like to know how this is actually affecting the practice. There's a need for future capacity building to support this PHN sector in implementing CSH approaches. This is really a new practice change for a lot of areas of nursing, and that comes with its own set of unique challenges. It's not as easy as pie and saying, here you go, we're going to change the way that you're working. Would you like to come along with us? It's a lot about, well, what systems are going to be in place at the organizational and the systems level to help that to happen. Do we need more resources? Do we need more funding? Are we going to reallocate staff? It's not just about capacity building in terms of knowledge exchange. It's about real on-the-ground capacity building, so we need to look at that. There's a need for strengthened partnerships. There is partnerships that are occurring between the health and education sectors around CSH, but something interesting to note that you may not know is that comprehensive school health is mandated in the health sector. It is not mandated in the education sector. So this is something where we're kind of getting into a situation of uneven progression happening on both sides, and it's happening in a very uneven manner across the province and across the country. So we're just going to continue to strengthen those partnerships and see the value in everybody contributing to this. And as for implications, I'm hoping that this project can support public health nurses in implementing CSH initiatives and the work that they're doing. I hope it will generate new conversations around public health nursing practice and comprehensive school health. And I hope that it will contribute to an area of nursing that is not known to previously have been evaluated. And again, I'm talking specifically about how these alignments are occurring. and I hope it will contribute to the growing research base on holistic health promotion and disease prevention initiatives, especially for the child health population. I want to acknowledge the following people for helping me out so directly and so immensely with this project. It's the reason why I have something to talk about today. So thank you all very, very much for your help and your support. Does anyone have any questions?
Thanks, Jennifer, that was lovely. I think, yeah, we're gonna get you a microphone, so I don't act like Sally, Jessica, Raphael.
Hi Jen, I just want to say great job. I just recently had a presentation on comprehensive school health, which I really didn't understand what was going on, even though I knew about comprehensive school health. So my question is DASH going to be coming in and doing some presentations to public health?
Yes, I think we are. I don't know but oh, by the way, I work for DASH now. I think we are. My role at DASH is actually the Health Authority Support Coordinator. So maybe I should be talking to you a little bit more. But I know that we have been to, and this is just from what I've heard, we have actually reached out to every health authority now. And now it'll be kind of repeating the process and seeing who wants. It's all about who, it kind of goes back to what you were saying in your presentation about meeting people where they're at. And do you want us to come in and give a learning session, and what would that look like for you, and how can we support you?
Come on in.
That's just kind of what we're doing. So definitely, if anybody ever wants a learning session, all they have to do is contact DASH, and we'll be there. We were actually in Prince George yesterday, which I was supposed to go, but I wasn't here. So yeah, so I think the director was in Prince George doing a learning session for Northern Health just yesterday, so I wouldn't be around.
I'm so jealous of your scope and maybe because mine had like 10,000 by the time I did my initial search, so it's quite jealous. But I asked this question before at the end of lunch, and I was just curious how your project can translate it into a job, because I think that's what all of us would like to eventually get to. Was it your project, or was it networking, and how you actually made that happen?
Well, what I did is I actually wrote a proposal for a job position at DASH, so I asked if I could create my own role. And that was tough. I've never actually written a job proposal before, and it had to go through the board of directors, and it had to go to the Ministry of Health and be approved by the Director of Population and Public Health, which happily to say it was. So they actually see a need for continued health authority support. So from this project, which I'm happy to pass around afterwards, after all the presentations are done, you're happy to take a look at them as copies. This is actually being redesigned into a resource that will speak to all health professionals instead of just public health nurses. I have to broaden the language a little bit, and because currently there are no CSH resources that exist that speak to public health professionals as an audience. So that's my job over the next 3 to 6 months, is to actually create that, have it approved by stakeholders in the Ministries of Health and Ed, as well as our community partners, and then actually roll that out. So the creation of the job was basically me taking a stab in the dark and saying, do you have any room in your budget for me? And so that's how that happened. I don't answer your question.
Yeah, no. I think it's excellent because everybody's experiencing a freeze right now, but you were able to overcome it.
It's good to work in a non-government organization. We're funded very heavily by the Ministry of Health, but we are not part of the Ministry of Health, so that's actually I've been learning a very interesting relationship to be in. On the one hand, you have so much more freedom and decisions. It's a very small organization, there's only 12 of us that actually work in DASH, and that growth has happened in the last year and a half. A year and a half ago, there was 2 people that worked at DASH. And I think before that, the executive director, the official address of DASH was out of her house in her garage. So now we have an actual office downtown, and we're all important.
We might have time for one more, but if not, then I'll thank you again, Jennifer. That was lovely. And Rebecca's going to also talk about Cape Waddington, Mount Peer Education in Reproductive Health.
Hi everyone. My name is Rebecca Olaf. I'm a public health nurse. I work up in Mount Waddington. I work at the Family Place, which is an outreach center for vulnerable families. And I did my practicum was a workplace practicum for VIHA in the Mount Waddington Public Health with a public health nursing formation. Just to give you a little bit overview of the focus of my project, it was to update and re-implement a peer education program that was functioning in Mount Waddington between 2002 and 2010, but it was no longer in operation simply due to staffing shortages. So just to give you a little bit of background, it's a program where older peers in grade 10 to 12 were trained to go into the grade 7 classrooms, which are about 9 schools or so, or 9 classes, and teach at an age-appropriate level the curriculum for reproductive health. It was implemented based on similar programs within VIHA, with the theoretical knowledge that peer education programs are well researched and effective at improving health outcomes, and it was really well supported in school district number 85. And it was something that our public health nursing team really wanted to re-look at re-implementing because it was so well supported. So practicum came along and it was a good opportunity. So in order to update the program, there were several components that were required. So first of all, a literature review was needed to support the program. The program needed to align with the BC Ministry of Education prescribed learning outcomes, and we'll talk more about that. It would need to fit within the comprehensive school health framework, and consultations would need to happen with key resource people to help shape the program, so it would have a shared vision. First, we'll talk about the literature review. So there was 2 parts to the literature review. The first was to determine whether peer education programs are effective at improving health outcomes. And the second, to determine what successful strategies were recommended for designing, implementing, and delivering peer education programs. So my methods, what I used UVic Summon as my search engine, and using the words peer education, sexual health. The title had to include peer, and it was limited to full text scholarly publications that were peer reviewed. And between for the last 10 years. And the process for my literature review was to I identified 47 articles in the initial search and reviewed all of the abstracts. I was looking at peer education programs that focus specifically on the elementary school, secondary school, and college and university student populations, and particularly looking at sexual health, communication, decision-making, and healthy relationships. Then I excluded some articles, 21 of them, and I created a reference or a table kind of explaining my exclusion. And then the full text was reviewed on 26 of the articles and critically analyzed for themes. The evidence was then graded and put into another nice table with an article critique. It was graded using the National Institute of Clinical Excellence guidelines, or the NICE guidelines, and using Some of them were hard to classify the studies, so I used this algorithm for classifying study designs for questions of effectiveness, which was also adapted from the NICE guidelines. Okay. So what I learned was effectiveness. It was really positive results for effectiveness. Peer education programs are highly effective at improving knowledge, attitudes, and sexual health negotiation skills. Behavior risk intent was also shown across multiple studies, but research was lacking in that area as to whether or not it was long-term differences made. There were exceptional results in the few programs that were well planned and implemented, and that incorporated strong both process and outcome evaluation methods. And so, although multiple studies showed effectiveness, more research was needed regarding the long-term effectiveness of programs. Oh, and then the second piece was the recommendations for success. So several themes emerged from the literature. For program design, programs that were theory-based, with clear goals and objectives, and that were evaluated were better. Recruitment of peer educators was a theme, and so we're making sure to carefully enlist peers that were influential, and ensuring diversity so that there was a match between the target group and the peer educators. Peer educator training needed to be completed over time and allow for learning and practice and rehearsal to be successful, and peer feedback. And teaching tools and activities. So it was recommended to use a variety to build on the curriculum and to build on previous curriculum, and to improve learning and improve teaching skills. And that had specific target outcomes. So the goal to increase knowledge and skill in decision making, health negotiation, and focus on changing social norms. So these recommendations I collated into a table, and that was a deliverable to my practicum supervisor. So we've learned a lot about comprehensive school health today. So thanks to Jen and Pam, I can briefly go over that. But comprehensive school health is an internationally recognized framework for supporting improvements in students' educational outcomes while addressing school health in a planned, integrated, and holistic way. And the reason why we need to consider the comprehensive school health, you learned a bit about that already, but from the VHA perspective, there was the Child, Youth, and Family Division formed a comprehensive school health project team in April of 2012 to engage both the education and the community sectors. And PHNs were encouraged to provide programs that fit within that framework, and only programs that were identified on the Healthy Schools BC website portal were priority for use. So we were really encouraged to only use those. And peer education programs were listed on there for both Port Alberni and Parksville. So we kind of felt a bit jealous about that and wanted to have ours up there as well. So we have the pillars, which I won't go into, but just to mention that the collaboration between the health sector and education sectors is a strength of the comprehensive school health approach, because healthier students are better learners, as Pam mentioned, and better educated students are healthier. So here we have my next slide, which was how I incorporated the 4 pillars into our reproductive health peer education program. And when we had a presentation by the nutritionist, it was great because she asked for some examples, and I was able to pull my slide up and kind of go through it with her. So, all right. So the next component I looked at was the BC Ministry of Education objectives. And so the Ministry of Education is responsible for the curriculum in public health schools, or public schools in BC. And the Ministry of Education objectives for sexual health education were updated in 2006. So our program started in 2002, and so we needed to make sure that they still aligned. And here, you don't have to read it, but it's just a table where I took the prescribed learning outcomes that were specific to health, and there was 11 of them, and compared it in the contribution table next to our peer education curriculum. And I was hoping to pull out a few ideas, and because it was not in the intent to be inclusive, completely full, but to meet some of them, and we actually in all areas did make some contribution. This contribution table was also a deliverable to my practicum supervisor. So through the course of the project development, collaborative partnerships, we've talked a lot about that today. They were key for my program as well to make sure that the project is supported. And collaborating across the health and education sectors and ensuring multidisciplinary development of the program was beneficial to making sure that it was a real shared vision, that it went kind of where we all wanted it to go. So with collaborative partnerships, so why are they important? For this program specifically, to assess and garner support for it, to provide constructive feedback, and to improve inclusivity and diversity. We had overwhelming support, and the principal of the high school in Port Hardy is now going to be moving next year to the elementary school, and he said when he was helping, when I was consulting with him, he just said, I really hope this program is functioning by then, because I really would like to see it come back. He had been a part of it in the past. So a component of updating the curriculum was to explore ways to ensure the curriculum was inclusive in language and content for both the Aboriginal and the LGBTQ community. And so LGBTQ is lesbian, gay, bisexual, transgender, queer questioning, and the acronym continues to evolve. So much effort's been made in School District 85 in regards to embracing and promoting Aboriginal culture within programming. And we want to ensure that our peer education program continued to do that and to meet the expectation of that in the school district. And the second component, it's actually the first listed, but also I questioned whether the curriculum provided support and acceptance of the LGBTQ discourse due to unintentional heteronormativity, which is pervasive in society, especially back when the program was developed initially. So we consulted with a number of different people, diversity students, Kyrie, I'll just mention Kyrie briefly. She was a student who got the peer education program when she was in grade 7. She became a peer educator in grade 11. She went to Queen's University for social work and did peer education among the university students. And then from that, she got a job teaching sexual health up in Northern Ontario in a little school for a few months. And now she's back in Mount Waddington as a youth outreach worker, as a social worker, and she came to talk about our new implementation and our cohort, and help me a little bit with some of the language. One of the things I wanted to talk about in the Aboriginal cultural component was the Transformation Celebration Working Group. So it was a new delivery method for sexual health in grade 8 and 9. And it really encompassed a traditional coming of age ceremony. And so we wanted our curriculum to kind of set the stage for that. And so that group was really key. And then, of course, peer educators will also each year be able to bring relevance to the program. So we have a literature review showing effectiveness and making recommendations for success. We have the peer education program fitting nicely within the comprehensive school health framework. We've met the BC Ministry of Education prescribed learning outcomes. And we have support across sectors and disciplines and consultations to support inclusivity. And so that information gathered was applied to the peer education program design and delivery and curriculum update, and that resulted in a comprehensive, evidence-based peer education program for grade 7 students. Here we have, here on the left, that's Kyrie, back in 2006. Oh, and at this point I'll just make my acknowledgements because I was afraid I was going to forget. So my practicum supervisor was Catherine Green, and she was really great at keeping me on task. And my public health nursing coworkers are fantastic, especially they're holding the fort, some of them, while we're here. So Meg and Mel and Pam and Sarah. And then also the faculty here, Victoria, Catherine, Lorene especially. And any questions? And I just want to point out, here's our peer educators for 2013. The program was accepted to continue, and we started a couple weeks ago. So maybe any questions?
Thanks, Rebecca, that was awesome. Questions for Rebecca? Sure.
I'd just be interested to hear more about the program and how it worked in the classroom and the supports from the teachers and their involvement, and yeah, just because you've implemented the program, right? Like it's in operation.
We've actually just, we recruited, we spent a lot of time recruiting peer educators and so far, and we have a really nice a group. There's 9 altogether between Port Hardy and Port McNeill, and they're quite diverse actually, so it's really great to see. Yeah, and some of them we had to target sort of specifically. The diversity group that I have spent some time with, a few of them have actually come from there, and it took a little bit of insight to get them. Interesting. Yeah, so we haven't actually moved into the classroom yet. We've done one session on teaching, and there'll be another full day, and then we'll go into the classrooms after that. Yeah.
Thank you, Rebecca. I was wondering if you could comment on the support from parents.
Oh, okay.
Yeah, anything around that.
Yeah, initially when the program was developed in 2002, there was lots and lots of consultations that happened. So with the school district, the Board of Education, there was a lot of parent sessions. This time around, no, we didn't go there and do that, except for that the students to participate, they need to have their parent support that they're participating, and then the students in grade 7, they will have a reverse consent form, so it'll be sent home that the peer education program is happening, and if they decline, they can do that, and they just have to send back the notice and have their child. Any other questions?
Yeah, this one up here. This time.
Thank you. That was a great presentation, thanks. It seemed to went by really fast, but I think I understood it was one of the studies that you excluded, that the title was Disappointments Coming from These Peer Education something, and I wonder if any of those, what were some of the things that you found when you were scanning the literature that really don't work with peer sex ed?
I don't know, I was waiting for you on mic for some reason. Forgot, I'm connected. It wasn't, the exclusion criteria, sometimes it wasn't a program that seemed to be, I don't know which one I had up there off the top of my head, it was just one of them, but it could be that it wasn't aimed at elementary students or secondary students or university students, or it may have been that the topic didn't really apply, so or it might not have been about sexual health. So those might have been some of the reasons that I can think of off the top of my head.
So one more question, and then we'll move on to ready.
Thanks, Rebecca, that was great. But I did the peer review program, sort of develop the peer-led, and that brings a lot of common points. My question to you is, I know from my literature review that professional support is sort of essential for peer educators to be successful. who is to provide that role in your program and what shape is it going to take?
Can you say it again?
Like the professional support.
Oh, yeah.
Is it EHM or school faculty or teachers?
The public health nurses. So the public health nurses are doing the recruitment and the training of the peer educators. And then we had, like I said, we had Kyrie come back, and she did a talk to the group about heteronormativity and heterosexism and talking a lot about that, just to get the dialogue going. And then we have support from the principals in the schools and the teachers. And when the peer educators go into the grade 7 class, they will have the public health nurse there sitting in the back in case that there's a question they can't answer, or in case things go where they shouldn't or something like that, to help guide. Yeah, and so it'll be public health nursing ongoing support.
Thanks very much, Rebecca. That's lovely. So next, Pam, is it Darden?
Yes.
Is going to talk to us about rural sexual assault.
Okay. All right. I'm Pam Reardon, and my presentation today is on rural sexual assault. So sexual violence is actually found across all geographic regions, cultures, and societies. It's, however, situated within the context of cultural norms and social structures. My presentation and report are attempts to look at sexual assault from the rural perspective. And then this is just a quote: attempting to solve the problem of interpersonal violence by dealing with the personal problems of individuals is a strategy doomed to failure. So if we look at it as a population health issue, we know that sexual violence is a problem of public health concern. It has tremendous impacts upon survivors, their families, their friends, and their loved ones. The responses to sexual violence affect individuals, but also our systems. So they affect our healthcare system, our criminal justice systems, and even our educational systems, such as universities. And then another quote: violence is experienced acutely by individuals, but its consequences and potential solutions affect society in general. So if we look at it as a population health approach, we're guided by prevention strategies and approaches. Sexual violence is very complex. It would be a great project for mapping with complexity theory, just as the obesity map that we saw yesterday. It's multifaceted. There are dimensions of child sexual abuse, intimate partner, dating violence, and community and cultural norms that impact. And those are just examples. Many disciplines are engaged with interest regarding sexual violence. We have much information over the last couple of decades specific to risk and protective factors for both victims and for perpetrators. Yet sexual violence continues unabated. So the integration of my practicum project, I was in a rural area. I was at a First Nations Health Center for my practicum. In this area, Mount Waddington, there are known to be very high rates of sexual violence and assault that occur. That came from a report by physicians, nurses, youth clinic nurses, a lot of community partners. There was a recent high-profile case that happened in our community that impacted many, many people in the community. There's this sort of talk about something needs to be done about this. The talk that came out of that was there's this sense of normalization in our community about sexual violence and about intimate partner violence. And so when I began to talk with the providers, they echoed that. And there's such a lack of resources to deal with the issue in the first place, from provision of care immediately after to ongoing counseling and advocacy for victims. And just to say, I was at a First Nations Health Center, but certainly Aboriginal women are definitely overrepresented among sexual violence and intimate partner violence, but it's not solely or exclusively an Aboriginal issue, but it is a gender-based issue. So literature review was one part of my practicum project, and I wanted to do a literature review specific to sexual violence that happens in rural areas. There's lots of literature available about sexual assault in general, but I worked to make it more specific to rural. Keywords included rural sexual violence, rural sexual assault, rural forced sex, and a number of keywords trying to keep that rural in there. I went to a number of databases, CINAHL, EBSCOhost, Science Direct, and a few others. I looked for articles and web reports that were published in the last 10 years, and English language. I took articles from North America, Australia, or Europe, just to be able to keep in scope. And then looked at websites from World Health Organization, Public Health Agency of Canada, and the Department of Justice. So I ended up with about 20 articles. I honed another 9 from reference lists, had 2 print books that were specific to Canadian intimate partner violence, and 5 reports from websites. 4 articles were excluded from my initial search simply because they focused very specifically on the sexual assault nurse examiner program. So, overview of the literature. Sexual violence affects all societies across the world and across all socioeconomic boundaries. That said, there are characteristics that can be described about sexual assault. Women and girls are much more likely to be victims, men the perpetrators. Men are usually known to their victims. Estimates range from anywhere from about 6% to 59% of all females will experience sexual violence from their boyfriends or partners in their lifetimes. And it's a huge range. So young women and girls are more at risk than older women, and more specifically, in Canada, children and youth in rural Canada have almost double the rate of police-reported family violence than in urban areas, with girls 4 times greater reports than boys due to just the increase in sexual violence. So the true magnitude is not well understood because of the limited reliable data, the vast underreporting, and the poor understanding of the larger issues. And those statistics are actually police reported. So there isn't real good data around non-reported. Rural crime and the social characteristics that surround it is one of the least studied areas of criminology science. Research in rural areas is very difficult to do due to insufficient numbers and insufficient power, and the increased vulnerability due to confidentiality and anonymity issues. So the World Health Organization describes a sociological approach that describes rape-prone cultures, and that includes cultures that accept interpersonal violence, male domination, and sexual separation. And that sexual separation is physical separation, but it's also the separation of gender roles. So looking at theoretical perspectives as to why, we can look at one theoretical perspective for a world that's called collective efficacy. And this describes the social support and shared value system often seen in rural areas. This supportive network can help prevent crimes such as burglaries and vandalism. It's kind of everybody looking out for one another and the neighbors all knowing the other neighbor's business. This supportive network can actually increase the barriers for women that are in violent relationships and deter victims from seeking any help. And I think that's really important to understand about rural. It can contribute to male peer-to-peer support for intimate partner violence. The life course development seeks to explain how early influences in life can increase the risk factors during later life for health problems and behaviors. With this, we can better understand and identify interventions and prevention programs to change those early influences. And then finally, the ecological model situates individual violence experienced within relationships within the community and the larger society. Risk factors can be identified that put people at risk of experiencing violence, as well as risk factors for perpetuating violence. And then that looks familiar to you with Jen's presentation, the ecological model. With this model, there's strong emphasis on multiple and dynamic interactions that go between the different levels. So inequalities between women and men are one example, and gender norms at the society level. At the relationship level, that can include witnessing violence between parents, and at the community level, that can include norms about acceptable activities in the community, and like binge alcohol abuse, or binge alcohol use, or even interpersonal violence that's accepted would be at that level. And then they all work together. So there is a very strong relationship with domestic violence. Intimate partner violence is inclusive of sexual violence. There's evidence of higher rates overall in rural and remote areas. Women in physically abusive relationships often suffer sexual violence from their partners, at least 40 to 50% of the time. That's actually a part of the intimate partner violence. Women in rural areas are more likely to suffer abuse, have more frequency and severity of abusive episodes, have fewer intervention services to choose from, and greater distances to travel in order to access those services. So often perpetrators are ex-partners or spouses, acquaintances, work or school colleagues, or persons in position of power or trust to the victim. It's worth noting that most women do eventually leave their relationships, but the opportunity to do so is not always available. Challenges to living in a rural area include that you're more often unemployed or underemployed, that you're maybe in a low-wage position than women in urban areas. You're more likely to be homeless. You have a greater chance of being in poverty, which can look very different in a rural area than it does in an urban area because of no access to public transportation, less opportunity for employment, and less community resources such as food banks or soup kitchens. The food bank in our area is you can go to once a month, and there's one food bank for the whole Mount Washington region. That looks quite different sometimes in urban areas where you can begin to kind of go to different agencies. The increased prevalence of abuse also includes an increased severity in rural areas, with abuse starting earlier in relationships, more threats to kill, more property destruction, more risk of harm to pets. And then that also includes farm animals. And sometimes women are really held back because of the risk of losing the family business or the farm, that they aren't able to seek help or report. So provision of care. Sexual assault survivors have very specialized needs, both immediate and long-term. The evidence indicates that long-term health issues are actually impacted by the care received in the immediate period. Namely, their acute care needs, prevention of pregnancy, sexually transmitted infections, forensic evidence, and especially that early counseling piece. So many issues about the nature of sexual assault that lend themselves to increasing re-victimization can occur during that immediate period. So it's really important that specialized training is done. Providing immediate counseling and anticipatory guidance and referral for follow-up counseling has been shown to decrease anxiety and PTSD or post-traumatic stress disorder later and long-term. The history of sexual assault, we know that there's increased use of health resources, health services, there's more physical complaints, more chronic conditions, more mental health issues. Some of the barriers in rural, we know the rates are higher, the resources are more scarce, and women are less likely to report, less likely to seek care. The reasons for this include just sheer lack of services, less personnel, and greater distance to travel. Rural populations are not homogeneous at all. There are other subpopulations within rural areas that are really important, and they may already have some health equities, such as people who have English as a second language, other ethnicities, physical disabilities, or the LGBTQ, as Rebecca alluded to. And they may have actually more consequential actions because of the lack of reporting and the inability to seek help. So, just specifically, women worry about being not believed or being blamed for being sexually assaulted. They worry they're not going to be helped, and they fear their perpetrators will seek revenge for them telling or seeking help, which is very, very real, especially in a rural setting. There's very limited data about rural-specific barriers. Some of the other issues that come out are around specialized training and services. Re-victimization is more likely to occur. Just things like providers saying that aren't reassuring to a woman are things like not believing her story and sort of pointing out blame, like, why would you even go there alone? And that women can take in very seriously, and it leads to those long-term impacts. Providers in rural areas are more likely to suffer vicarious trauma, just because they often know the victims, the perpetrators, they see them in community. And realizing that some of those attitudes actually cause harm to a victim, not that they're just not understanding what to do. So I think there's a bigger question about why are there differences in rural populations, and I think this is just one example of the intersection of rural health with other social determinants of health and health inequities. So rural areas often have no voice at the larger table where policy issues are concerned. This means health issues, transportation issues, economy issues, jobs, all of those kinds of things. So we need to ensure that we take a moment to look at the impact to rural areas when we are looking at policy and healthcare decisions. And just the implications for public health practice. We want to look at prevention strategies upstream, looking at violence prevention for families by caring for women and children. Rebecca's program, I think, is a good example. And also the program that Melanie gave just about right from the start, and then Jen talking about school health and that comprehensive school health. We need to support families, and some of the ways to do this are making sure that women have jobs, that there's microfinance programs, that's in the literature, changing power dynamics, and the peer education, the gender-based education. And then we need to improve care for sexual assault victims. Okay, I think I sped through that. So acknowledgements. I want to acknowledge my practicum supervisor, Tanya Petrick, who's a nurse practitioner in Mount Waddington. She was awesome. Meg, who's the public health nurse at the Gosselin Aqueduct Health Center, who helped with her hours so that I could get enough of my hours in. And the youth worker at Gosselin Aqueduct who really helped. We did a project together. And then my partners in crime, Rebecca and Mel. And then my cheerleading section, Marie and Joan McNeil is here today too. And then thank you so much to Yvette, Victoria Barr, and Catherine and Maureen for reading.
Okay, questions for that?
Thank you, Pam. That was really interesting. Thank you so much for bringing up the rural issues and how it is different. And I think that's such as we've talked about this past semester over the phone. I think it's so important for us in public health to remember and start to develop more fully. And I think here at UVic we can do that through the MPH program. So I really appreciate you bringing up those issues so beautifully, so eloquently, and trying to also talk about the complexities of issues within rural areas. I do have a question though.
Yes.
And I wanted to, if you could address please how your project integrated with the practicum work you did on reserve, because I think that you haven't really talked about your day-to-day work in the practicum and how this is connected. So I'd really like it if you could address that.
And I think we definitely talked about that around the practicum supervision, is that I kind of viewed it when I first started as, okay, here's my practicum and here's my practicum project, and I wasn't sure they actually really met, but I think by the time I ended up finishing it, I realized how much alike both of them were in terms of just that ecological model and understanding all the dynamics that happen to oppress women, to oppress a people, and the ideas of colonization and history and all of that sort of stuff all kind of came together at the end. And by no means is sexual violence, limited to Aboriginal population, that's for sure. But they definitely are overrepresented, and it's because of all those larger issues, especially the societal factors. So it was really interesting how I thought they were very separate in the beginning. They actually kind of came together in the end, and it gave me much greater understanding. Did that answer?
Thank you, Pam. That was very interesting. Thank you. I have a burning question about, we were talking about the data on sexual assault incidence rates is coming from the police reports. If that's happening, then that means that the categorization of a report of sexual assault as violent would be dependent on how the police officer attending the call would be classifying that. So I'm just wondering, do you know if there are currently any formalized partnerships in place between public health and the RCMP to develop any standardized protocols so the RCMP are reporting these incidents in a uniform manner so that the data can be pulled out from that to actually accurately reflect the type of sexual assault that's occurring?
Well, it's quite interesting because I did actually interview the RCMP for my, I did a mapping of services. There was so much that it's really hard to kind of condense all of that into, but I did a mapping of services for the Mount Waddington area and tried to identify what gaps in service. So there weren't a lot of services available to map, to be honest with you. But I did interview the RCMP, or talked with them, and the Victims Assistance Services, which are located in the RCMP. So when I called the RCMP, that's who they referred me to. They really wanted me to talk with the Victims Assistance. And since they're situated within RCMP, that's who oversees it. And so the Victims Assistant person was actually really good about telling me that there are issues with being located within RCMP around reporting. So she has to tell somebody, if they call her, that she has to ask them if they've reported yet. And if they haven't reported yet, she has to tell them, whatever you're going to tell me, I could be a witness to and get called on the stand for. So she really wants them to report so that she's not a witness anymore, which just seemed, that really takes the power away from a woman who is in that circumstance, and that's really what you want. You know, in order for her to heal, you actually want her to have that power of deciding who to tell and how to tell her story, and that is completely taken away. So there are definitely issues, and I think there's real issues around having victims assistance programs located within the RCMP. They really should be a separate arm, and they should be, you know, sort of driven by that. So yeah, I mean, it's like this.
We also know that only about 6 or 8% of sexual assaults are ever reported. So.
I think it's like 6 to 29%, like across the world,
Yeah.
looking at what community. And I know in our community, it's very small.
I actually had a question. I'm familiar with and I'm not sure if you're familiar with Hollow Water, which is a group of 4 communities in Manitoba, 3 Métis, 1 First Nations community, that had a real alcohol problem in the 70s and 80s that they decided to pursue sort of addressing. And what they found was that a lot of the alcohol abuse was a result of sexual assault and sexual abuse that was really quite severe, sort of what you're talking about. And that community undertook a process of restorative justice. And they're a model now for, and what they've been able to do over the course of, I don't know, 10 years or so is drastically reduce not only recidivism of sexual assault, not necessarily the rates, but the recidivism, more so than any other program, as well as a lot of the alcohol abuse and relationship problems that were occurring. Has the community, I did have a question, has the community pursued anything about like where the perpetrators of the violence are actually held accountable and any services provided to them and to the victims' families?
No, I think it's very early stages.
Right.
And what I'm going to do after this presentation is I need to go back up to present. The nurse practitioners are very, very interested in sort of taking this forward. And I think what we would like to do is see somewhat of a SART program, which is a sexual assault response team. The Crisis Center was really very interested in setting up some advocacy. They used to have an advocate program, but they never got called, so they've since sort of disbanded that. But to be able to put all of those things in place and then to get the nurse practitioners, possibly I think a combination of the nurse practitioners, the public health nurses, and some emergency nurses that are very interested, and try to get them off for some SANE training, and then be able to kind of all work together with the Crisis Center, a rape advocate program, and really be able to that as a start, and then be able to take that out to community in terms of prevention. But that would be great to look at that model. So very early.
I think we're running sort of close to the time, so thank you very much. Our last presenter of the day is Kate Elliott, and Kate is going to be talking about structural violence as it relates to Métis people.
We probably should have really planned the day so we ended with that really nice, cute picture of the baby. So you guys can go with we give them two down.
You got her mic?
Just on a bit of a side note, we did set up some kind of cultural stuff as well as the art-based product that the youth produced. So do you guys want to go around and just take a peek there? So first I want to acknowledge, I don't know. Awesome. Again, I just want to acknowledge the traditional territory that we're so grateful to be on, of the Coast Salish and Strait people. Also, I'd like to kind of start with a bit of introduction. So I decided to pursue research. Don't judge me. I'm not 100% sure what I was thinking at the time, but I've had a wonderful opportunity, and I just wanted to thank my youth that actually participated within this research project, as well as the elders and Kathy Richardson and Kathy Camilleri. which I think a few of you are connected with. So my project was Breaking Through Structural Violence, Métis 101, and it was participatory action research as well as art-based. So, a bit of introduction about me. My name's Kate Elliott. I'm Cree Métis. My family comes from the Red River area in Manitoba, and I belong to the Métis Nation of Greater Victoria. You guys are probably super confused because every time I talk on the feeds, I'm talking about something different. I'm over here doing this, and then, you know, operating room stories and all that. So, I have quite a diverse background. And I'm also the Minister for Youth and Métis Nation and Sport for British Columbia. So the reason why I mention this is, you know, thinking back to our qualitative research of looking at that notion of ourselves as a researcher and looking at that kind of what type of powers does it have? Because I am in the leadership role, and how does that impact the youth? One of the nice things is, though, is I am the voice for Métis youth within British Columbia, and I have no real power to fire anyone or inflict much trouble, so it wasn't really a conflict of interest. So I don't know where everyone's background is about who the Métis people are, but my story is, like many Métis people, I grew up knowing I was Aboriginal, but we weren't allowed to talk about it. I am quite fair. Most of my family is not, and my grandma told us, you look the way you do is because you're Jewish. I went to a Catholic school. So we know something's not quite right there. Can anyone tell me who that picture is? Awesome. Oh, I'm so excited. So our good friend Louis Riel is pretty much one of the most iconic kind of Métis figures. It's kind of like Captain Jack Sparrow from Pirates of the Caribbean. You know, you got the mustache going and kind of that lovable trader. So kind of looking at, you know, who is Louis Riel as one of our icons is that, you know, he's either known as, you know, a father of Confederation of Canada, or he is a trader. There's not a lot of research on Métis. We are quite a difficult population to study. One thing that did come up is, for most Métis people, we don't know who our mothers were, or our aunties, or our grandmothers. It just said Indian woman. There's a play by a Cree man, and it was called Translators, Traders, Mistresses, and Whores, Monica Moget and Other Mothers of the Métis Nation. I don't know, that for me, when I was going through my process, it kind of really stuck with me, that title. And just, you know, how are our kids grown up to, you know, really foster that pride of being Métis. Unlike Captain Jack Sparrow, unfortunately, Orlando Bloom didn't come and save him, and he was hanged on November 16th, 1885. So on my slide, I do have a little bit more of the traditional definition of the Métis. One of our elders, Tom McCallum, you know, he states the Métis are in an era of resurgence and reclaiming their identity. So this is one of the big pieces of where Métis people are situated right now, is that it's just starting to become safe to come out and acknowledge your heritage and say, I am proud to be Métis. I question that we're not. This is in the infancy, and this will take some time. So I'm talking about structural violence, and it's a very kind of academic term. One of the biggest form, well, not the biggest form, one of the things I think is very interesting is that we acknowledge Louis Riel and what he did for Canada, either traitor or father of Confederation, on the day they killed him. He was hung on November 16th, and in British Columbia, that's the day we celebrate him. I don't know if that would really fly if we celebrated JFK because he was shot or Princess Di. It's just one of my personal kind of what mixed messages are we sending. So structural violence is entrenched in the fabric of society, and it's permissible and even encouraged. So when I'm talking about structural violence, and more specifically what we worked with the youth, was the notion of institutionalized racism and how do systems continue to oppress. Colonization also falls under that umbrella of structural violence. And kind of touching back onto that whole health equities, is structural violence occurs when one group or structure monopolizes resources and then penalizes others for lacking those. So that's where we really get that creation of the health inequities. So the purpose, we were looking at how subtle and explicit forms of structural violence are woven into the lives of Métis youth. How does it affect their health and well-being? And what strategies can they use to overcome or resist this violence? I'm going to go really quick because I really don't have that much time. So theoretical background, we're looking at the social determinants of Aboriginal health, that Métis identity, that history, structural violence, obviously, and I really, really want to make sure that this research was based in that Indigenous paradigm of respect, relevance, reciprocity, and responsibility. I'd love to go into depth about my methods and my consultation with working with different youth and leaders and consulting the elders. I sat with this project for a really long time of whether I wanted to bring it into my community, is because I wanted to do right, and I really, held that responsibility and that ownership on me to make sure that I wasn't causing damage. So what we ended up doing is taking 10 Métis youth up to Tofino, and they engaged in a 4-day leadership retreat. And so for participatory action, we went for more of an intense 4 days versus doing it over a prolonged period, just based on schedules and what's kind of the needs of that population. So the youth did 2 art projects. One is the Métis flag, and each youth decorated a panel that represented their kind of thoughts and reflections around structural violence, and I have it over there. And we also utilized the analogy of the canoe. So you'll see pictures just coming up. So the youth put the things that they want to leave behind them. So that's your structural violence, your racism, shame, anger, alcoholism, drug abuse. And then the canoe itself was what keeps our youth afloat, culture, language, elders. And then we also did a bit of visionary of where do they want to go for the future. And then, just to mix it up, each youth did their own paddle. So what tools are they going to utilize and want to carry forward to bring them into that positive future? I have a video for you, and hopefully it works.
Your eyes, they tie me down so hard.
Violence, and I think even though it's an education term, we need to kind of define it. It's really important to put a name on it.
My candle bright, learn me hard, oh learn me right. This ain't no sham, I am what I am.
Prior to the development of Canada, who immigrated across Canada and mated with Aboriginal descent, and have created a new nation.
I have no strength from which to speak. When you sit me down and see I'm weak, we will run and scream. You will dance with me. They'll fulfill our dreams and we'll be free.
Most Canadians may not understand or recognize what being Métis is, and when a person lacks an identity, how do they feel good about themselves and have positive self-esteem and self-efficacy?
Structural violence mean to you?
It has made me more aware of why my family has hidden their ancestry.
Your primary and secondary education, we're taught to sort of devalue ourselves. We're taught that Métis people means real, and that's it.
I was on my knees.
I think structural violence is a huge component of history that's tied into it and completely unable to remove from it.
I am what I am. I'll leave no time cynic's mind.
I can definitely say that institutionalized racism or structural violence certainly does affect our health and well-being and affects our self-esteem.
Like structural violence, I think it has a rippling effect on people, and I think that leads to problems like alcoholism and drug abuse.
As Métis people, we're focused on health as in our mind, spirit, and body, and that isn't understood everywhere.
As it keeps my heart and soul in its place, and I will love with urgency.
From the Cree, traditional knowledge from the Irish, the jig, and to gain all these things and bring them together and keep practicing them, right? And speak Michif. Speak Michif with each other, right?
Your eyes, they tie.
And the way that we will get by it is to educate people, to share our knowledge.
I'll never learn to put up a guard.
Say it's okay to tell people you're Métis. It's okay to say, it's okay to let your history out to people and show them what you fought for.
This ain't no sham. I am what I am.
I think we just need to remind ourselves of all the amazing things that we are doing in our community, and it's hope for the future.
Recognizing Métis and non-status and off-reserve Aboriginals around is really important.
I have no strength.
If policymakers listen to youth, Métis youth, and what we had to say, listen to our voices, go a long way for the future.
You will dance with me.
That it doesn't continue and that we educate the public about who the Métis are, as in the past structural violence has made people become ignorant about who the Métis people are because everyone's gone underground and hidden and been ashamed of it.
Scar sadness will be.
So I was just not feeling ashamed, because I think that that's something that we have been definitely taught, is that we should be ashamed of who we are, we should hide our identity.
So as we walk through fields.
Sorry, the credits are like 14 seconds and I have 3 minutes left. So just a bit of things that kind of came up. One of the things is the youth that we had there were all leaders, they were all educated, they were also passionate about giving back to the community, but yet there was this sense of shame that most of us didn't know what to do with. Like, why do we feel this way? Why are we taught to feel this way? Like, some of the youth are just so amazing. One of them has gone and advocated for the rights of Indigenous children in the world to the United Nations, right? So where does this come from? I think one of the big things that came out with this is, this notion of Métis 101. In British Columbia, we're not that well understood. And I think that's really going to be our biggest fight is, who are we? Who are we as a nation? Because policymakers don't understand and government don't understand. And on that one-to-one interaction, you end up having to teach people about the culture and who the Métis people are. And unfortunately, it's not a lot of teaching. It's usually defending. And to have to be put in a place to defend, usually not just yourself as an Indigenous person in Canada, usually you're fighting for the other 600,000 Indigenous people in Canada and still dealing with that racism that is out there. Another thing is just, the culture. The culture is really what's going to keep us moving forward and keeping us healthy. Also, I think belongingness, one of the interesting things that also came up was that, that whole notion of pan-Aboriginal doesn't really work with our Métis youth. We're not there yet. We don't have those relationships formed. And there's that whole, well, I'm not white, and I'm not First Nations, or even sometimes I'm not Aboriginal. The Métis feel it from both sides. There is a very strong, again, other Indigenous people, and it's just based on that they don't know who we are or know our history. Because our coping mechanism for most families was to hide about, again, Jewish. Yeah, and I think there is a notion within government and stuff about, you know, I think the further, especially I go with my journey of, you know, talking to government and stuff, is that there's almost that sense that you're worthless, you know, that all these other people are so much more important and you're not entitled or you're not valued. I'm totally not articulate, and I had a really good speech written, but I've totally gone off track. So next steps, some of our youth are going to do lunch and learn, and to help educate their peers within the provincial government about who the Métis people are. Again, the Office of Aboriginal People Action Plan was something that I was involved with, where we actually had executive directors of the provincial and federal government saying, you know what, I work within an Aboriginal focus, but I don't understand who you are, you know. But now, again, engaging in culture sharing and being in a safe context has really started to create some change. A bunch of the youth reported that, you know, they feel a little bit more comfortable teaching people about who they are as Métis, and they feel that they can stand a bit stronger when they do encounter that racism. Any of you who know me, I'm a big doer, and I think my biggest reflection of what the youth did and all the fantastic work is that these kids are so smart, and they don't need to be studied, they just need to be heard. Like, my video was long, but it should really be a half an hour to really acknowledge and honor the participants. One interesting thing that we're doing, and hopefully on Sunday, I'll know if we got the funding for it, is we're going to host a Métis youth gathering, and we're going to have a gala. And the youth who participate in this research, as well as others, are going to go and invite key stakeholders to come and learn about who they are as people, and about their culture. And you know, this is an opportunity where key stakeholders can actually deconstruct some of that structural violence, but our youth actually have the opportunity to say, you know what, I'm proud to be who I am. And I went way over time. Again, I would just, thank you. My presentation was voluntary, so I appreciate keeping you guys on a Friday afternoon. And of course, our funders, Aboriginal Affairs, Northern Development Canada, and CHAR, and the Métis Nation of Greater Victoria, first and foremost. And my supervisors and everyone, you guys are all wonderful. There was a reason why I compared Lou Real to Captain Jackson. I had so much more anecdotal stuff and funny stories to share with you, there wasn't enough time.
Thanks, Kate. Questions for Kate?
Tell us about your practicum, Kate.
Oh, all the other wonderful stuff that I did. My practicum was with Aboriginal Recruitment and Retention with the Vancouver Island Health Authority. So we were looking, the mandate of this team is to look at health from a different perspective and say, like, you know, VHA has a mandate to improve the health of Aboriginal people, but, you know, let's think about health, and that includes employment. So the team recently expanded, and they went from being a team of 2 when I was involved with them as an undergraduate student to a team of 6. And so working with them was fantastic, and I looked at, I kind of designed 4 Aboriginal mentorship programs that could be applied for different target populations. I also organized, along with the Aboriginal Youth Collective, health conference that took place in the beginning of March. And, oh yes, I also did an Aboriginal employee handbook, which is to help Indigenous employees kind of, get to know VHA, what supports are out there for them, what are their rights, and help make that transition into the culture.
Mine is kind of a comment / question, and in a way it takes us back to the opening speaker today. And so just by way of background, there is a process called Increasing Health Research Capacity for Vancouver Island that has been spearheaded by VHA in collaboration with numbers of other partners, including the University of Victoria. And out of that process has come a desire to really focus on 4 areas. One is health services, the others are populations, seniors, people with mental health conditions issues, and Aboriginal populations. And so I guess my question out of that is, as we move forward on this, A, would you be available to sort of consult around how we might do that? And B, what kind of advice might you offer around trying to create partnerships, engagement, to really focus on the role of health research in improving health outcomes, as opposed to getting off on looking at things under a microscope, whether that's actually literally or metaphorically?
I think it's really important, and that was the first time I've actually heard about that collaboration. And again, just to echo what my peers have said, collaboration and relationships are really what make us healthy, and creating those things. I think regarding for Aboriginal health is, going into communities, but giving them the ownership. With my youth, I never, ever, ever want to make a video. I do not have the skills. I've spent 100 hours trying to recover data. But really knowing what they want and what they need and how to satisfy that, I think, one of my things I had to check a lot of my political beliefs and kind of my experiences when it came to do this, because it was about the youth and those voices. Even though I'm a member of that Métis youth group, I think it's just, if you go into Indigenous communities, is really know that you could start wanting to do something, but you could come out completely on the other side doing something different, but know how wonderful that can be and how much positive change that can create. I kind of answer it kind of on a tangent. Right after.
Hi, Kate.
Hi.
Good job. The recent Supreme Court judgment on the Red River settlement, what do you think that's going to do in terms of this breaking through structural violence issue in Métis 101?
I think it's created a little bit more awareness. I think we're very differently situated, Métis in British Columbia versus Manitoba. Manitoba, there's Métis flags everywhere, and you really don't have that experience of having to educate every single person or to defend yourself as an Aboriginal person. I think there is still some of that violence that happens, but it's not as much as it is out here. The Daniels case was huge. I actually had the privilege of listening to Dave Shaw trying to talk about that, and that was his movement. I think it will, but I think there's going to be a lot of challenges before that really happens, because a lot of people are quite scared. We also had the Supreme Court ruling that Métis people and non-status are actually considered Indians under the Constitution, so that implies that we're wards of the Crown. Therefore, the non-insured First Nations benefits needs to be applied, and as well as the Indigenous rights. I think a lot of people are really scared about that, and I think a lot of government's really scared about the land claims as well, because that'll completely reshape how we view the Métis. Personal bias, we recently just lost a huge bunch of educational support for Métis and non-status, and I think it has to do with that Daniels case that just came out. It's really a shame, but there's different ways in how you have to fight against this, and one of the tactics is if you cut people off at the knees or try to run them out of the money, which is something that we've seen, especially with the line claim course. We got a good fight in us.
Thanks very much, Kate.
class of 2011, so entering cohort number 1. So we thought it'd be kind of nice to recognize the faculty as well as the staff. So Joan, Carmel, Doug, everybody in the office behind the scenes, Lorraine as well. So we have a little card that everyone in the first cohort has signed, as well as not just graduating this year, but everybody who started with us in September of 2011. And so we got you, it's a Bill Reed, so you can hang it up in the HSD office. And the card was covering it, but I'll read you quickly the back of it because we thought it was kind of the perfect one for this occasion. So it's a picture of the Haida Raven in copper, and at the heart of Haida intellectual world is Raven, the cultural hero and catalyst responsible for dispelling darkness and discovering humankind. So we thought it was really fitting for the public health program, so thank you.
Well, thank you to all of you. I have to say that just to watch all of you over the last 2 days has been amazing. I went back to my office at lunch and sort of sat down and thought, okay, so what is it about these presentations that has captured so much? And I can tell you some of the broad themes that I hear, like that broad vision of health that includes the structural, the social, and the contextual determinants, and really understands that in deep ways, and the synergies that happen between universal programs and targeted programs, and some of the discussion that you've had about that, and some of the values of alliances and collaborations, and how people work together in partnerships and intersectoral work and interdisciplinary work. And I think particularly when I look across the room and I think of the range of placements and the kinds of things that you bring is just amazing. And of course building on the strengths of the collective, and we've heard that throughout the two days. But when it comes right down to it, when we think about projects, we think about the culmination of your program. And I know you're not quite done yet, but you're so close. And we can feel how close you are too, just so that you know. And when I think about that, I also think about what are the attributes of people that we want to see in what are the attributes we want to see in our students, we want to see in our graduates. And what I just, so after sort of all those, thinking through all those themes, I think what really came to me was this whole idea of having a really open mind. I think it was Julie that said earlier that the more I learn, the less I know. And I think part of that is having that open sense of inquiry and the ability to go wherever it takes you. And in public health, it takes you lots of different places because it's such a broad field. And just to see you do that over the past 2 days and uncover again and again and again as we start to understand how complex the whole realm of health is just fabulous. And if there's one thing that I could pick to have in graduates, it would be to have that critical, open, inquiring mind. So I just want to say how well done the projects were and the presentations. We're thoroughly pleased with what you did, and so I just want to acknowledge all of you and our appreciation of that. So when we hang this in our office, and we will, just know that we'll think of all of you in that. I also wanted to do some very specific thank yous. And I want to acknowledge both Victoria and Betty for the practicum. This was the very first practicum placements, the very first practicums in a new school, and that takes a lot of organizing and all of those kinds of things. So to the two of you, I really appreciate that. And all throughout the 2 days, we've also had different people with us who were practicum supervisors. And Marie, I know you've been here both days. And so again, thank you so much. It makes such a difference to have the support from our community in terms of our placements. And the next person I want to acknowledge is actually Kathy, because it's a lot to take on 18 projects, and Kathy has done that with a lot of finesse and a lot of, I hope, good support from all of us. But her leadership in guiding you through those projects was really important, and so I just want to acknowledge you, Kathy. And then the other person today that I really would like to say thank you to is actually Carnell. Carnell actually got all those presentations. So I really appreciate it. And thank you to the videographers for doing the sessions. We really would like to close and get you out in fairly good time. But I think what we'd like to do in closing is actually, particularly for the students that are in the cohort of 2011, and the rest of you are quite willing to stay and pipe in with whatever you would like to say. But I'm just wondering, we don't exactly have a circle in this room, but I'm wondering if you can sort of just move through.
The classrooms, I think, are vacant.
Are they vacant? Do you want to move, or are you quite comfortable here just going through the room? I actually will pass the mic so that everyone can hear. What would you like to do? Move? Okay. So, Lynn, maybe we'll go and check. That will give you a few minutes stretch. We're just going to actually, and I'll say, this is particularly focused for the class of 2011. The others of you are welcome to leave or join us, whichever you choose to do. And we will move over to the classroom and just do a closing circle, because we would like to go around and have you each have an opportunity to say a few words.